This presentation is to talk about some of the general thoughts behind pain management, while the latter half of the presentation will focus on ALS treatment of pain. We will spend some time discussing BLS treatments. So why do we care about pain management? Nationwide, pain from any number of sources is a primary reason patients seek care in the emergency room. Here in Yosemite, we provide ample opportunities for patients to hurt and break themselves, and to do so in areas that are difficult for us to extricate them from. There's growing concern about harmful side effects of painkillers, particularly narcotics. But on the flip side, nationwide studies have shown that emergency medical providers often fall short of addressing patients' pain. Although Yosemite EMS providers are often faced with patients in acute pain, whether trauma or medical, and periodically see chronic pain concerns, I want to take some time to review some of the basic tenets of pain management and discuss the overall pain management goals in Yosemite EMS. So what is pain? Pain sensors and sensory nerve cells, or neurons, are found in nearly every location on the human body and respond to stimuli such as pressure, pain, and temperature. These neurons convert the stimuli into electrical impulses, which are sent to the spinal cord and into the sensory cortex of the brain. Fast-traveling pain impulses will be sensed by the brain in about 1/10 of a second from the time of stimulation. The concentration of pain sensors affect how a person feels the pain. Areas of the body, such as the fingertips, that have a high concentration of pain sensors will be much more sensitive to pain than an area with a low concentration of pain sensors, such as the abdomen. Pain originating in areas with low concentrations of pain sensors will be described as achy and diffuse and have other non-specific complaints. Sensory nerve cells that run adjacent to other sensory nerve cells may send overlapping signals to the brain. This causes the referred pain phenomenon, where a patient senses pain in an area different from where the painful stimuli occurred. A common example of this is left arm pain with cardiac chest pain. How does the body react to pain? Pain sensations are the body's way for tissue to tell the brain it is being damaged and that it needs to react to preserve itself. Initially, in response to painful stimuli, the sympathetic nervous system will be kicked into gear. Epinephrine will be released, and in response, pulse and blood pressure will increase, along with other effects. Patients that are unable to fully activate the sympathetic system, such as patients taking beta blockers, may have a different presentation in response to pain. Additionally, some patients may stimulate the vagal nerve in their reaction to their pain, which would increase the parasympathetic response and present with bradycardia or hypotension. When the brain senses pain, it will also release endorphins, which bind to opiate receptors on the neurons and thus decrease the pain impulses. Opioids work in the same receptors within the neurons that decrease the pain impulses. Pain is subjective. While providers can visualize certain injuries that cause pain, a provider cannot quantitatively measure pain as they do a pulse or blood pressure. The only real measurement providers have of a patient's pain is what the patient says it is. To a certain extent, providers use other clues to determine the level of pain a patient is experiencing. The patient's demeanor is often a huge clue, though not always a reliable source since patients react differently to pain. Visible injuries can help us determine how much pain a patient is experiencing, but patients may often be in significant pain without obvious deformities. Because of the difficulty in assessing pain, a thorough assessment is critical, particularly for pain without an obvious cause. Having the patient quantify the pain on the 1 to 10 pain scale, having them use a different word to describe it, such as achy, stabbing, or squeezing, and also finding the exact areas of pain or referred pain is important. Pain as an assessment tool. Throughout EMS, There has been a fear that if we remove a patient's pain sensation, providers down the chain will not be able to fully assess the patient. This is a particularly widespread belief with abdominal pain. Withholding pain medications due to future assessment concerns is not the right option, however. It is imperative that the provider completes a thorough examination prior to pain medication administration in cases where there is not an objective cause of the pain, and that the provider gives a detailed handoff to the next provider. Providers can also consider the duration of the pain medications they are giving. For example, it might be appropriate to administer fentanyl, which is relatively short-acting, instead of Dilaudid, which is much longer acting, so the patient has a better sense of their pain when they arrive at the emergency room. Within Yosemite EMS, always call medical control prior to administration of pain medication for abdominal pain. Chronic pain. Patients may be experiencing chronic pain from a variety of sources, whether a medical condition such as fibromyalgia or diabetes, or chronic injury such as back pain. Cancer pain is often classified completely separately from acute or chronic pain, as the stimuli is acting on a completely different system. EMS generally does not see patients solely because of chronic pain. Patients may, however, be experiencing breakthrough pain, or pain that is beyond the patient's baseline. This may be caused by unusual activity, such as a chronic back pain patient who decides to hike up to Nevada Falls, or there may be no apparent cause for the increase in pain. Providers may also encounter chronic pain patients who have an unrelated injury, such as the back pain patient who trips and falls and breaks their wrist on the way up to Nevada Falls. While treating a patient with baseline chronic pain by administering narcotics may not be the best treatment option, EMS should treat breakthrough pain or other causes of pain for chronic pain patients. Patients who experience chronic pain may require a higher dose of narcotics to achieve the same effect. Be sure to ask about other types of painkillers the patient is on, both controlled and over-the-counter, and call medical control if you have any concerns about medication interactions. Pain is not static. A patient's pain level may fluctuate during the call. The patient may be moved or move themselves, resulting in an increase in pain. Injuries may also swell during transport, which would further increase the pain level. Just because a patient begins reporting their pain at a certain level does not mean it will not change in either directions. Providers can anticipate certain changes in pain level, such as when they're going to splint an injury or move a patient. I have here a very rough graph of changes in a pain level based on a call. Initially, the pain may spike because of splinting or moving the patient, then generally decreases as the patient becomes less mobile. Injury may swell during transport, increasing the pain level, and also when the patient is transferred to the receiving hospital or ambulance, the pain will again increase for a short duration. We will come back to this chart in a couple slides. So treating pain, BLS methods. Narcotic administration is not the only way EMS treats pain, but as providers, we often neglect some of the simpler pain management techniques. Some BLS techniques to remember and try before moving on to ALS techniques are position of comfort, placing a patient in the position of comfort on the cot, or making them more comfortable wherever you might have found them in order to perform an assessment. Placing pillows or blankets beneath the patient's knees may make the long ride on the ambulance far more bearable as well. Splinting. A well-applied splint not only decreases the chance of further injuring the patient, but minimizes movement within the injury, resulting in less pain. Properly forming and padding splints will affect the patient's pain level. Ice pack. Icing injuries will reduce swelling, which will reduce pain levels. While icing is an important part of injury management, don't over-ice the injury or apply cold packs directly to the skin. Distraction techniques. Patients who have nothing better to do than think about their pain will report higher pain levels. This is a great time to play up your bedside manner and keep the patient's mind occupied. ALS pain medications. Yosemite EMS has several different controlled substances that they'll use to manage pain, including fentanyl, which is a potent synthetic opioid with an onset within a couple of minutes and a maximum duration of approximately 30 minutes. Dilaudid, or hydromorphone, is a synthetic opioid with an onset of 5 minutes and a maximum duration of 4 to 5 hours. Toradol, or ketorolac, is a potent non-steroidal anti-inflammatory drug, or NSAID, with an onset within 20 minutes and a duration of 4 to 6 hours. Ketamine is a general anesthetic that at lower doses creates a mild dissociative effect. Onset is within a minute and total duration is 10 to 20 minutes. Versed, or midazolam, is a benzodiazepine with an onset of 2 minutes and a duration of 20 to 30 minutes. Yosemite's protocol does not include any pain management indications. However, in certain cases with medical control contact, Versed may reduce a patient's pain when pain is caused by muscle spasms. For example, a patient with a fractured femur begins experiencing extreme pain from legs, muscle spasms, and cramps. If Versed was administered, it would help relax the muscles, thereby decreasing pain. Again, this is only an indication when contacting medical control. Using ALS pain medications together. When considering which pain medication to administer, consider what you are trying to accomplish. Are you trying to reduce pain for a long or short duration? Does the patient have to be extricated, splinted, or otherwise jostled about? A common pattern for EMS calls is again depicted here with my very poor charting ability. Again, just as a review, beginning of the call, when the patient is moved more frequently, pain level goes up, goes down as they become more sedentary, and it may fluctuate through transport based on swelling. And again, at the end of the call, when the patient is being moved, the pain level goes up. If we anticipate some of these pain increases and decreases, we can better utilize a range of medications to appropriately manage the patient's pain. So to further expand on and demonstrate my very poor Microsoft Paint charting techniques, we now have a few more lines in this chart. In this chart, an example of a combined pain management plan is shown. The orange lines are ketamine doses, the purple are fentanyl, and the blue Dilaudid. The green line is the perceived pain by the patient after pain medications are given, and we still have the red line based on the patient's perceived pain without any pain medications. Let's say that this patient has an isolated extremity injury, such as an open tib-fib fracture. The patient is in considerable pain when EMS arrives. Soon after, the patient completes a rapid assessment and determines pain management is appropriate prior to moving or splinting the patient. An initial dose of ketamine IN is given, then shortly thereafter a dose of fentanyl. After a couple of minutes, when the medication begins taking effect, the patient is splinted and packaged, which the patient still perceives as painful, just not as much. Second doses of ketamine and fentanyl are given during this process. As the patient is loaded into the ambulance, the providers start thinking of longer-acting pain management. A first dose of Dilaudid is given, which maintains the patient's pain level for most of the transport. 10 minutes or so before the transfer to the second ambulance, a second dose of Dilaudid is given in anticipation of both the effect wearing off and the upcoming movement of the patient. Of note with this call is pain medications were used somewhat fluidly. Initially, the patient received ketamine, then once the heightened pain stimuli was removed, ketamine was withheld. The provider also switched from fentanyl to Dilaudid once longer-acting pain medications became appropriate. The provider also anticipated the administered doses of pain medications wearing off. The second dose of both ketamine and fentanyl were given well before the first dose wore off, avoiding the peaks and valleys effects of waiting until a patient's pain level is increasing before administering a second dose. Additionally, if you notice, the patient's pain level never goes away entirely. Setting up realistic expectations for your patient that you are managing the pain and helping reduce the pain, but not taking it away completely, will have them perceive a better effect. Drug seekers. Yosemite EMS, compared to other EMS systems serving a more stationary clientele, probably sees fewer patients who are actively seeking narcotics. However, providers should always fully assess the patient and situation to determine the best course of action. Yosemite EMS also does establish relationships with residents of the valley and may see a pattern of behavior develop with certain patients. Regardless of one's history with a patient, always treat the patient based on his current situation instead of the patient's history. Generally speaking, a pre-hospital provider does not and should not bear the same burden as doctors when determining if a patient truly is experiencing pain. In the pre-hospital setting, it is very difficult to determine what the true nature of the patient's situation is. In general, EMS providers should always assume the patient is telling the truth about their symptoms until specific points in their story or assessment proves them wrong. Don't assume that a patient, based solely on your past knowledge of them or the initial appearance of the call, is seeking drugs and not experiencing real pain until you complete a thorough assessment. Most drug seekers are looking for a prescription, not a single dose from EMS, which reduces the burden on EMS providers. However, inconsistencies to look for in your assessment or in the patient's story are drug allergies to multiple medications, except for the one they're seeking, the patient articulating the exact drug and dose that they'd like to control their pain, the patient refuses to consider other treatments or medications, such as icing or ibuprofen. Also, look for evidence of prescription drug abuse, such as an inappropriately large quantity of medications. Again, thanks for bearing with me through this presentation. Let me know if you have any feedback, and remember to complete the quiz in order to get credit for the CEs and for the ketamine sign-off.